Congratulations to the local committee for an excellent meeting and in this beautiful city. So I'm going to spend 15 minutes just covering infections resembling tumors. The goal here is to stay out of trouble, avoid mistakes, avoid missing diagnoses. All pediatric orthopedic surgeons and many orthopedic surgeons are going to be seeing children who have infections and possibly a tumor. and some of these are many infections will present like a tumor or tumor-like lesion. And the ones we'll talk about mostly here this afternoon are eosinophilic granuloma and subacute osteomyelitis. The bottom line is that the biopsy with intraoperative frozen section will help you from missing these diagnoses. That's the punchline for this lecture. So get the biopsy. A hand-carried intraoperative frozen section is highly valuable, and the imaging, especially the MRI, can help you tell what you're dealing with. There's a saying in life that when you hear hoofbeats, think of horses. In the tumor world, and especially in pediatrics, you need to think of the zebras. This is a patient who presented with a swollen ankle, red, hot, swollen, had an elevated SED rate, low-grade fevers. The surgeon that initially treated this patient did an IND and encountered pus or purulent material. Patient was put on antibiotics. The signs and symptoms continued. The patient was transferred, and to make a long story short, on a second biopsy with intraoperative frozen section, this lesion had small round blue cells and was a Ewing sarcoma. And we all know that Ewing sarcoma patients do have elevated white counts, fevers, and inflammatory markers. So in this case, the horse is the osteomyelitis. But remember the zebra, which in this case is Ewing sarcoma. And of course, the great Sherlock Holmes stories were written by Sir Arthur Conan Doyle, and he, of course, was a physician, and we, like Sherlock Holmes, have to use all of these signs and symptoms and be detectives and try and get it right the first time. The location of the process can be very helpful, as shown in this slide. The mnemonic that we teach our residents is this FAHEL mnemonic, and this just helps us remember those tumor-like processes that have a predilection for the diaphysis, and those being fibrous dysplasia, adamantinoma and its pediatric variants, LCH, Ewing sarcoma, lymphoma, leukemia. But down here in the bottom, subacute osteomyelitis can also be a diaphyseal process. The epiphyseal processes, Brody's abscess of the epiphysis, we'll talk a little bit about that, and that can mimic a chondroblastoma. They look a little different, and then all of these tend to occur mostly in adults, and these are processes which evolve eventually the epiphyseal ends of long bones. And finally, metaphyseal, which is the most common, and pretty much anything can involve the metaphysis, so it doesn't help you too much there. But as stated before, the key, when you have a patient, when you take them to the operating room, get a frozen section. What I do is if I'm in one of these high-risk situations with an aggressive appearing lesion, including osteomyelitis, I'll put lesional tissue, the best lesional tissue, small piece in a cup, label it, hand carry it myself, hand it to the pathologist, and I'll show them the imaging. I'll give them my differential diagnosis, and then they show me through their microscope what they think it is. And that process is time-consuming. It takes 5 to 10 to 15 minutes, but it's highly valuable in any situation where you have an aggressive appearing lesion. And here's an example. This young man presented to a prominent orthopedic surgeon in the Philadelphia area, had pain and swelling. This orthopedic surgeon with very good intentions went in and did an IND, encountered pus, and thought it was an osteomyelitis, contaminated the extensor mechanism of the knee. And this, again, turned out to be a primary bone sarcoma. And with this type of a surgery, it's impossible to do. The preferred operation, I think even 10 years ago, would have been an endoprosthetic reconstruction. This patient with this surgery could not have a limb-sparing surgery and ended up undergoing an intercalary amputation, otherwise known as a modified Van Ness procedure. So an unfortunate tale of events for this patient. And it's very important, even in the face of suspected infection, to remember where to place your incisions. This is an article by Peabody in Clinical Orthopedics Related Research. I would highly recommend this for any residents or registrars in the audience as far as staying out of trouble with biopsy locations. Again, in the context of that last case, avoid the extensor mechanism even above the knee and especially below the knee, and the neurovascular bundle in other locations. So acute hematogenous osteomyelitis, again, the acute phase, you're not really going to see much on plain x-rays other than the soft tissue swelling. This one has some very early changes. The bone changes don't occur for about 7 to 10 days. On MRI, however, there's this occasional serpiginous appearance, which is very helpful, and the soft tissue edema is visually different than a soft tissue mass. And David gave an excellent lecture, but the one addition I would make is if you see a soft tissue mass on an MRI with a spine lesion, you have to do a biopsy. Infection generally will not create a soft tissue mass, but if you have a soft tissue mass of significant size, it's not going to be LCH and unlikely to be most of the common types of osteomyelitis. So I think in that situation, if there's a soft tissue mass, a biopsy is warranted. So subacute hematogenous osteomyelitis, this is the one that we'll focus on in the context of this topic. The symptoms here have been present for over a month, and the x-rays are abnormal at presentation. There's this classification, and I'm going to go through and show you some examples of these different types of subacute osteomyelitis, and then the counterpart tumors that can present like this. The first is this punched out lesion, or what we call the 1A subacute osteomyelitis. And why do you get subacute osteomyelitis? It's a combination of decreased virulence and increased host resistance, likely, and perhaps the fact that patients are healthier and get on antibiotics earlier. And they're usually staph or strep species. And here are some of the differences graphically between subacute and acute. Again, the subacute patient will have less white count elevation. The laboratory values are usually not that remarkable. And again, this diaphyseal location is much more common as compared to the metaphyseal location with acute osteomyelitis. And again, fewer signs and symptoms present in that group of patients. So here's a patient with a metaphyseal lesion. This one has a wide zone of transition. It looks aggressive. And this is a type 1 subacute osteomyelitis. Here it is on bone scan, lighting up with no other lesions. Now, is this a soft tissue mass, or is this pus under the periosteum? Usually with cancer, you're going to get a circumferential soft tissue mass, but not always. So when I saw this, I didn't know if this was going to be infection or sarcoma. I thought probably infection, but sarcoma was on the differential diagnosis. Also, but here's this metaphyseal destruction. I thought infection was leading or more likely than sarcoma. And at time at biopsy, again, this hand-carried intraoperative frozen section showed, instead of small round blue cells, this one showed inflammatory cells, polys, plasma cells, lymphocytes. So a mixed, for subacute, is going to be a mixed acute and chronic inflammatory reaction on your frozen section in final H&E slides. Here's another patient, 8-month-old with, this can't be an 8-month-old, but a pediatric patient with right hip pain, 1-month history of signs and symptoms, and here it's really not the proximal femur, but rather the acetabulum with these localized areas. So that's the type 1A, that's the punched out lesion, and you often think of LCH as a punched out lesion, so that's in the differential diagnosis. The type 2 has more of a sclerotic rim, and that's more of the Brody's abscess. And Benjamin Colley Brodie was one of the early surgeons working in the mid-1800s, I think in Ireland, if I'm not mistaken. But he was the first to describe this, and it's really a localized subacute osteomyelitis that's walled off. The body, for some reason, is able to wall these off. And here's an example. Now, on this one, I thought, well, this could be an osteoid osteoma, but usually with osteoid osteoma, the sclerotic bone completely encircles the nidus. This one had this interruption, or this serpiginous, on MRI, serpiginous type of appearance. So this in turn turned out to be a Brody's abscess, or one that had a localizing, walling off sclerosis, if you will. So that's the type 1B, radiographically thin rim of sclerosis, periosteal reaction. MRI shows lesion marrow, a lot of edema in the marrow. increased activity on bone scan, and these often require a biopsy for diagnosis. Staph aureus is the most common organism. And this, of course, is the cousin, the true osteoid osteoma, with this mature periosteal, thick, aggressive, mature periosteal response, non-aggressive, with this central nidus. And there's, and be careful on MRI. On MRI, these osteoid osteoma nidus can look very aggressive, and with some of the newer imaging MR sequences, you can make the diagnosis, but we prefer the CAT scan. If the patient has night pain and relief with aspirin, go straight to fine-cut CAT scans to avoid confusion with MRI. Here's one in the cervical spine before and after. So here's the next patient, a 7-year-old with a history of limping, joint pain, and leg pain. You can see something going up here in the proximal fibula. It lights up on bone scan. A lot of edema, not a true soft tissue mass. And this, again, the serpiginous type appearance here, you get a suggestion of that, an incomplete sclerotic rim. And this was consistent, again, with this Brody's type of response. So I think as you look at these images and gain experience, you'll be able to recognize these and create a better differential diagnosis. And then go to the operating room with the frozen section to confirm that. Here's a type 3, and this is where it's breaking through the cortex. Again, this looks very aggressive, diaphyseal lesion. So be careful, get that frozen section, rule out tumor, culture everything you biopsy, biopsy everything you culture. And in these, especially these diaphyseal lesions, remember Langerhans cell histiocytosis. Eosinophilic granuloma is the terminology for an isolated lesion, and in the children with multifocal and sometimes hepatosplenomegaly and other involvement is historically referred to as Handschuler Christian, letter Siwi, more fulminant form in infants. It's all the same thing. It tends to involve the vertebra. Here's a true coin on edge vertebra plana. Looks very different than what David showed you with the discitis. And on these, I'll get an MRI. If there's no soft tissue mass, I will not biopsy these. But if there is a soft tissue mass, then you're thinking about Ewing's sarcoma, leukemia, and in the older children, lymphoma. But this is what you see under the microscope with LCH, these Langerhans giant cells, lots of eosinophils, and these peculiar-looking histiocytes. And these look like coffee beans. They have a longitudinal nuclear groove, and you can immediately recognize these on frozen section. Very characteristic coffee bean appearance, and you see the giant cells and the eosinophils, and they're also CD1A positive. That's an immunohistochemistry test that's done later to confirm. So here's an 8-year-old boy with diaphyseal leg pain, and here he is a month later. Here's his MRI, again, more of an edema picture rather than true soft tissue, but not so sure on that image. But here's his frozen section, and what is the diagnosis here? Here's the coffee beans. This is Langerhans cell histiocytosis. And this perhaps is a subacute infection. We've done a series of experiments linking this to human herpes type 6 virus. We haven't proven that, but it behaves very much like a viral infection or an infection of bone. It gets better without treatment. Here's one of these Bierbeck granules, which is the same size as the HHV6 virus, and their immunohistochemistries are always strongly positive for HHV6, but it's very difficult to prove that with Koch's postulates. And here he is 3 months after biopsy, and here he is 12 months after biopsy with nothing other than a biopsy, no chemotherapy, no medications, no steroids, just a biopsy. And I believe, and the evidence is emerging, that you really don't need to treat those patients with chemotherapeutic agents. Here's a 16-year-old chronic leg pain. Here's the images. Is that cancer or is this osteomyelitis? Final diagnosis, osteomyelitis. So again, the imaging can help you with that differential diagnosis. And then finally, the last, or second to last type is this epiphyseal osteomyelitis. It's a Brody's abscess of the epiphysis. Looks very similar to the ones shown before. But remember chondroblastoma and the osteochondroses here. These kids do well, but again, they usually require a biopsy just for confirmation. And here's another epiphyseal lesion. Is this a chondroblastoma? I get 5 or 6 of these a year, and they're sent in as chondroblastomas, but they turn out to be osteomyelitis. And this one you can see that it doesn't look like a chondroblastoma. It's breaking through or eating through the cortex, and that turned out to be a epiphyseal Brody's abscess or subacute osteo. Now here's a chondroblastoma. This looks a little different. Lots of inflammation. There's usually at least a thin sclerotic rim, and under the high power you'll see these chondroblasts and chicken wire calcification. Here's the chicken wire calcification surrounding those chondroblasts. And this was treated with a 4-step curettage, high-speed burring, cautery, and phenolization with a structural tricortical autograft and bone graft, and that patient did well. And here's a spine lesion. Is this discitis? No, there's collapse of the vertebral body. There's really not much of a soft tissue mass on that MRI that you saw, and this was consistent with osteomyelitis, but could have been Langerhans cell histiocytosis. Here's one. Now, is that a true soft tissue mass? This is kind of the upper limits of what you see with LCH. This turned out to be LCH, but this one I biopsied just because it tended to have more of a soft tissue mass. We talked about the Bierbeck granule. Here's collapse. This was a partial collapse in a 10-year-old with a 2-month history of back pain who had eosinophilic granuloma or a partial vertebra plana. Here's a complete vertebra plana. And again, generally do not need chemotherapy. We do get skeletal surveys and bone scans to look for other lesions. About 10% of those patients will have something else. We look for hepatosplenomegaly. The classic triad of exophthalmos and diabetes insipidus is very seldom seen. I don't think I've ever seen that, and yet it's described as a classic triad. Here's another patient with low back pain, MRI changes, no true soft tissue mass, so that would bring infection to the top of the differential diagnosis, and that's what that was. And that's the last type of subacute osteo, is this spinal osteomyelitis. And then finally, CRMO. This is a very peculiar entity, chronic recurrent multifocal osteomyelitis. It has a tendency to involve the clavicle. Occasionally, you'll see this palmar plantar pustulosis and arthritis. They tend to be older children, pain and swelling, low-grade fever, and they tend to burn out with time. And this, again, is probably some sort of self-limiting, perhaps viral etiology. If you see clavicular osteomyelitis, many of those patients will go on to develop a CRMO type of picture. But this one, I think you got a biopsy, because there is, that's a little aggressive looking, scary looking, so I would biopsy that. The key with CRMO, though, is to not biopsy again and again and again and again. You should need maybe 1 and at most 2 biopsies, and then you know what it is, and when the next lesion arises, you don't really have to do much for that. The natural history is best spelled out by Cole, showing that these patients do very well with just non-steroidal anti-inflammatory treatment. And it's different from JRA, and it can involve the spine, as shown in that slide. So the treatment is mostly conservative. The key is to make the diagnosis without a lot of surgical intervention. So the bottom line here is to avoid over-treatment, but be careful you don't miss the diagnosis with another. And here's a patient with multiple sites. This turned out to be CRMO and resolved with antibiotics. And finally, just a word about leukemia. This certainly does occur. The bone changes of leukemia are generally quite late in the course, so you'll see a lot of kids with high-grade metastatic leukemia developing bone lesions, but they can occasionally present with bone lesions before the diagnosis of leukemia is made. So keep this on your radar screen and be aware of it. George is going to talk about tuberculosis, musculoskeletal tuberculosis, so I'll skip over that. And remember and know some of these other atypical conditions. So the keys to staying out of trouble are experience, pattern recognition, careful evaluation. The history and physical examination of value cannot be overstated. Good imaging, but most importantly, when you go to the operating room, take the time to get a frozen section if you're dealing with an aggressive lesion. Confer with the other specialists. Go by the book. Play by the rules. And I think you'll be able to avoid mistakes. Thank you very much.
Thank you very much. Any questions, please? Go to the microphone, please.
Thank you.
Please go to the microphone.
Have you come across a situation where even the biopsy does not help whether it's a tumor or an infection?
Where there's no diagnosis?
Even the biopsy is not helpful.
Where the biopsy is non-diagnostic?
Yes.
We see that a lot with the interventional radiology CT biopsies, and we've studied that, and they are about 50% diagnostic. The trouble is they put the patient to sleep, they put a needle in, get a small piece of tissue, wake the patient up. When the surgeon takes the patient to the operating room, you should not leave the operating room without a diagnosis. If I carry what I think is lesional tissue up to the pathologist and it's non-diagnostic, I go back down and I get more, and I stay at it and I stay at it. And each year there's 2 or 3 patients where, in spite of very aggressive biopsies, even on final pathology, it's non-diagnostic with just maybe a mild inflammatory response. But that, for me, is a diagnosis of exclusion supporting a low-grade infection. So those patients where you are doing very aggressive biopsies and there's nothing diagnostic except for maybe low-grade inflammation, that's...
I totally support your view. Yep. Biopsy must be taken by a senior person or in the presence of a senior person, and sufficient amount of tissue should be sent.
Yeah.
Because the pathologist will say the tissue sent is insufficient.
And give them your best piece. If you give them a large cup of everything, they're going to have trouble. But I will put aside the best small piece and have them freeze that piece.
I had a patient where radiology, tumor, upper end of femur, pain, nuclear study, tumor. Somebody made a diagnosis of osteomyelitis, give incision, pus came. The discharge kept on persisting, antibiotic given, again subsided. 3-time biopsy could not decide what it is. I am from India, so there was a discharging sinus. I put that patient on my clinical suspicion on anti-TB drugs. And that patient responded very nicely to the anti-TB drugs. In India, we are seeing many patients of tuberculosis where the biological behavior, whether we are giving antibiotics which are having anti-TB effects, so a proper, even the histological picture does not come. And your clinical suspicion and the response of the patient, that ultimately leads you to decide what it is. Yeah. And second thing, I will congratulate you, which you have said, in case of osteomyelitis, when you are suspecting, Ewing sarcoma should always be kept in mind, and the fluid which you get, that should not be sent only for culture, it should be sent also for histology. Mm-hmm. Thank you very much.
Thank you.
Thank you. One last question.
Thank you very much, John. Duhay, Montreal, Canada. Listen, a case presentation. 10 days ago, I had this patient came in. These new people immigrated to Canada from Algeria. The child is 23 months of age. And they've been in Canada 5 months, and they're waiting for their Medicare card before consulting. 2 months ago, the child stopped walking, didn't want to walk, complained of pain. 3 days before consulting, that's 13 days ago, he started to walk. So he comes into the clinic, he's doing very well. He's not toxic. So my clinical examination is looking for a Lake Perthes-like disease, probably, of the hip. I'm not thinking of tumor. I think of osteomyelitis, subacute, because he's doing well. The SED rate is 23. The blood count doesn't give you anything special. The other lab is about 10. So normal is 6, and it's 10 CRPs. Okay. Now, my clinical examination is normal. I think it's vascular necrosis in the younger child. And then I take an X-ray, and there's a lesion on the metaphysis of the neck, upper part, superior part of the neck. So then I say, I ask for a bone scan. The bone scan says, because I still do bone scans, ask for a bone scan. It says nothing. It's not osteomyelitis. Now, clinically speaking, now I changed my mind. Now it's not avascular necrosis. It's, for me, it's subacute osteomyelitis. So the child's doing very well. And I left the child with the fellow when I left. And I told him to be careful with that. Now it could be osteoblastoma. It doesn't look like a tumor. It doesn't look like a, it's not a reaction. So from what you said, the child's doing well, but maybe I should perform a biopsy nevertheless.
Yeah, if there is aggressive imaging, if the plain X-rays show an aggressive lesion, I'll do a biopsy just to...
The lesion is there, though. To my surprise, there's a lesion there.
Yeah, and the other thing is if they have night pain relief with aspirin, I'm going to get a CAT scan with fine cuts so I don't miss that. The MRI I find very helpful, but in my practice, I do a lot of biopsies. If it's an aggressive lesion, I want to know. That way I sleep well at night and the patient gets the best care. But they will burn out. Some of the subacutes will burn out on their own. And the history here is interesting in that he's getting better just before he presents to you. And so that makes me think of CRMO a little bit, but your bone scan showing just one lesion rules that out. But my tendency would be to biopsy that. It could be LCH, it could be subacute osteo. It sounds like it's unlikely to be cancer, but the MRI would help you most with that.
Thank you.
So thank you, Chick.
Well, thank